Can start.
Sir, please make me the co-host, sir.
Sakshi, can you please mute?
Where go?
Sir, should we
You have to mute everyone. I don't know what's happening.
Dr. Navne, please unmute yourself and begin, please.
Good evening, everyone. On behalf of the Research Society of Anesthesiology, Bathinda branch, I extend a very warm welcome to all of you to today's webinar on the theme Special Considerations for Cardiac Arrest in Unique Situations. We are privileged to have with us our esteemed President, Dr. Naveen Malhotra sir, President-elect Dr. Anju Garewal ma'am, and Secretary Dr. Vishal Singla, along with distinguished chairpersons Dr. Madhvi Julakanti, Dr. Shelly Mittal, and Dr. Devyani Desai, who have kindly joined us for this academic session. The management of cardiac arrest becomes particularly challenging in special scenarios such as trauma, obesity, maternal cases, and when ECMO support is considered. Today's session brings together experts who will share their insights and practical approaches to the management of these unique situations. I'm confident that this evening's deliberations will enrich our understanding and strengthen our preparedness in handling these emergencies. Thank you once again for joining, and I wish you all a very fruitful session. Now I invite our Honorable President, Dr. Naveen Malhotra sir, to deliver his presidential.
Thank you, Dr. Navni, and heartiest congratulations to Team Research Society of Anesthesiology, Bathinda City Branch for organizing this conference. My regards to Professor Tej Kaul sir, and I'm thankful to the three chairpersons, Dr. Madhvi Julakanti, Dr. Shelly Mittal, and Dr. Devyani Desai, who have accepted our invitation to share their valuable time with us today evening. I convey my appreciation to Dr. Navne, Dr. Gigal, and very dear Dr. Anju Grewal, who will be sharing their inputs, academic as well as clinical, pertaining to the different aspects of today's webinar. And thank you, Dr. Vishal, for continuously organizing these webinars. I won't stand between you and the academic event. Let the academics flow. Thank you very much.
Now I invite Dr. Vishal Singla to deliver his address.
Good evening, everyone, and my special regards to President Dr. Naveen Malhotra sir, our patron Dr. Tej Kaul sir, Vice President-elect Dr. Anju Garewal ma'am, our esteemed chairpersons Dr. Madhvi Julakanti ma'am, Dr. Devyani Desai ma'am, and Dr. Shelly Mittal ma'am. And I especially congratulate our team, Research Society of Anesthesiology, Team Bathinda, for organizing this webinar under the able guidance and leadership of Madam Dr. Anju Garewal ma'am. Not taking much of your time, we are already late. I would ask Dr. Navnesh to please continue. Thank you very much.
Now I invite Dr. Gigal Pruthi to continue with the session.
I invite Dr. Madhvi Julakanti, Professor and Head, Nagar, Telangana. Dr. Shelly Mittal, Head Anesthesia, Artemis Hospital, Gurugram. Dr. Devyani Desai, Associate Professor, Department of Anesthesiology, Government Medical College, Vadodara, Gujarat, as chairpersons. Thank you, ma'am, for joining.
Good evening, everyone. My heartfelt thanks to Dr. Naveen, Dr. Vishal, and Anju Garewal ma'am for giving me the privilege to chair this session today. Special regards to Kaul sir. So our first speaker is Dr. Gigal Pruthi. She is an associate professor at AIIMS Bathinda. So she has numerous publications to her credit and has been an active part of organizing committees of several conferences and workshops. So she will be speaking on traumatic CPR today. So over to Dr. Gigal Pruthi.
Thank you, ma'am.
Dr. Gigal, you may please share your screen. You have been made the co-host. Please share your screen.
Yes, sir.
On.
Are my slides visible?
Yes, please go ahead.
Yes. Good evening, everyone. Today I'm going to present cardiac arrest in trauma bay, an overview. First of all, traumatic cardiac arrest. The outcome of TCA, that is traumatic cardiac arrest, it is poor, and resuscitation of these patients is still by many regarded as futile exercise and a waste of precious resources. So recent studies have reported very less survival to discharge rates, that is 5 to 7.5% after appropriate resuscitation. Whereas indeed one military data has reflected 24% survivorship following CPR after TCA. So the differences in survival in TCA, it depends on the expertise and the elapsed time since loss of the vital signs. Unless injuries are incompatible with life, resuscitation must be attempted. So when injuries are incompatible with life, like decapitation, extensive cardiac destruction, or massive head injury with loss of brain tissue, then the resuscitation must not be attempted. The good neurological outcome has been reported only in 2 to 6.6% of the survivors. And now, what is the difference between traumatic cardiac arrest and the medical cardiac arrest? Medical cardiac arrest, mostly it occurs in adults secondary to the cardiac pathology, whereas traumatic cardiac arrest, it is almost always associated with a reversible underlying cause. Now, what are the most common causes or the preventable causes of early death in trauma? These are remembered as HOT, that is hemorrhage, airway obstruction, tension pneumothorax, and cardiac tamponade, with hemorrhage or uncontrolled hemorrhage accounting for 48%, tension pneumothorax and cardiac tamponade approximately 13 and 10% respectively, and airway obstruction or asphyxia accounting for 10%. So simultaneously, we have to address all these reversible pathologies along with the chest compressions. The most common rhythms which occurs in TCA or traumatic cardiac arrest are PEA, that is pulseless electrical activity, accounting to 66%, asystole in 30%, and VF is in 4%. Now the heart may be beating in these patients but has nothing to pump, because most common cause, as we have seen, it is hemorrhage or the uncontrolled hemorrhage. So the successful resuscitation of these patients, it starts with the conceptual acknowledgement of these underlying processes. So we have to understand the mechanisms, what is happening in the patient in TCA. So there is a change in the mental model. What happens in ACLS guidelines, there is some change in the traumatic cardiac arrest guidelines. So regarding the chest compressions, unlike AHA ACLS guidelines, we have to de-emphasize the chest compressions. Why? Because in when the patients are euvolemic, the CPR results in cardiac output of 25% of the baseline in the medical cardiac arrest, assuming that patients are euvolemic. But these patients are having, where in these patients the heart is empty, the hemorrhage is ongoing, or when there is an obstructive component, that is tension pneumothorax or cardiac tamponade, the cardiac output is minimal. So if we give chest compression this time, there is no use. So the focus in these patients should be on the mechanism of traumatic cardiac arrest. So what do we do? Do we let go initiation of chest compressions in these patients? What are the guidelines for the traumatic cardiac arrest CPR? So the first decision that has to be made is whether a non-traumatic case is more likely than a TCA. If this is the case, the standard ACLS algorithm should be followed. But if this is not, then the priority goes on tackling the usual suspects, that is HOT. We have learned hemorrhage, obstruction, tension pneumothorax, and the cardiac tamponade. So first of all, if the so-called the reversible causes of TCA, these are the reversible causes, so which are to be addressed in a simultaneous fashion. So we address according to the CAB approach in these patients. So we first approach the C, that is stands for the catastrophic hemorrhage. So we recommend to address the massive external hemorrhage with simple measures as external compression and tourniquets. Then re-establishing the oxygenation has the highest priority in the asphyxic patients and patients with brain impact apnea. This can be achieved using simple measures like oropharyngeal airways, supraglottic airways. And if we suspect tension pneumothorax as the cause, we recommend open thoracostomies as these patients will need pleural decompression. And needle decompression is an alternative if the practitioner is not trained in the finger thoracostomies. For controlling the massive diaphragmatic hemorrhage or traumatic cardiac tamponade, what do? We do resuscitative thoracostomy. It should be considered. And ideally, this should be done in emergency OT, but may be carried out in the emergency department or in the pre-hospital environment also. In case of uncontrolled diaphragmatic hemorrhage, also it is recommended that you can do cross clamping of the descending aorta, so that if you apply a clamp on the descending aorta, it will act as a temporary measure to achieve the proximal control. And also there is a term known as REBOA, that is resuscitative endovascular balloon occlusion of the aorta. It is an alternative to the descending aorta clamp application. So these both techniques are non-inferior to each other. Both the techniques, it should only be performed if you have 4 E's. That is, if there are sufficient expertise within the team to carry out the procedure safely, if the right equipment is available, and the patient is within the right environment, and the loss of vital signs is less than 15 minutes. So after that, we recommend use of pelvic splint if a pelvic fracture is suspected, and also the guidelines recommend that early transfusion of blood products is mandatory, which is a cornerstone of the treatment in these bleeding patients. And if return of circulation can be achieved with these measures, the patient has to be taken to the immediate nearest hospital for damage control, resuscitation, or for the definitive care. And in these patients, we have learned that do not think of putting LMA or endotracheal tube initially if the cause is not obstruction. So instead, if the patient is bleeding, then instead seek your reversible causes and stop the bleeding source. Now coming to the role of epinephrine in traumatic cardiac arrest. As we know, epinephrine increases the aortic diastolic pressure, which augments the coronary perfusion pressure. But if the mechanism of cardiac arrest is not hypoxemic, if it is hypovolumic or obstructive, then epinephrine is not physiologically, it does not make any sense. So summarizing, we know that if the patient is bleeding, if the if the TCA causes are hot, then first start your wide bore central venous catheter or take the IO-XS intraosseous. Start the PRBC's FFP in the ratio of 1:1. Hemorrhage control with the REBOA or aortic clamping. Then open the airway if the patient is asphyxic. Take supraglottic airway devices or the ET tube. And also for the you can use bilateral finger thoracostomies or the resuscitative thoracotomy if there is cardiac tamponade or penetrating chest traumas, because it will also facilitate your internal cardiac compressions. And pelvic splint and emerging role of ECLS is there in some of the patients. So along with this, if you have done all these things, then go ahead with the chest compressions, which should be high quality, and also teamwork matters, and then debriefing should be there. Thank you.
So that was an excellent presentation, Dr. Giegel, and just to the point, precise. So yes, you're absolutely right. If hemorrhage is the cause, unless and until you give fluids or the blood volume, unless and until you build up volume of the patient, definitely compressions are not going to help for that particular patient. So I think we can move on to the next speaker, and maybe we can have questions at the end of the session, right? So,
Dr. Navne, you have been made the co-host, and please go ahead with your slides, sir.
Can I request the chairperson to introduce Dr. Navne, Dr. Devyani or Dr. Madhvi? If not, I think we can ask Dr. Navne. She's an associate professor at AIIMS Bathinda, and she has been the organizing secretary of the recently successful RSSCP Con that we did in March 2025. So we can ask Dr. Navne to start her slides. Shelley, you can continue your chairperson role.
yeah, yes, okay. Yeah. So I will invite Dr. Navni for the next talk, and she will be speaking on NSAID challenges for obese patients, CPR challenges for obese patients.
Ma'am, are my slides visible?
No.
Please share your screen.
Sir, are they visible?
No, you haven't shared the slides.
Dr. Navne, if you have your presentation with yourself in your mobile, you can send it to Dr. Giegel. She can present on your behalf, or you can send it to me.
Yes, sir. No, I am not able to upload it. Maybe. Excuse me. You have presentation. Share the Shared it with Dr. Giegel. Giegel, can you?
I think Dr. Navne, you can send to Dr. Vishal.
Yes, ma'am.
And in the meantime,
Okay.
I think we can go ahead with the next talk.
Okay. So our next other chairpersons are there.
Yeah, ma'am. Very good evening. Coming to a very
Shared my presentation. Giegel,
Shall I share or
Please, ma'am, please share the presentation, ma'am.
thank you, Dr. Giegel. Good evening, everyone. So today I'll be speaking on CPR challenges in obese patients. Dr. Kegel, you'll have to do the slide change. Thank you. So as we all know, in the world, 30% of the population is overweight or obese. And even in our country, more than 30% are obese and more than 5% are morbidly obese. Sudden death is more common in those who are naturally fat than in the lean. The leading causes are cardiomyopathy, CVD, and it occurs more commonly in young patients. So now I would like to ask, will effective CPR be a challenge here? So coming to the changes in physiology due to obesity, in the central nervous system, there is a decreased central respiratory drive. Airways associated with potential in obese patients, there is a potential difficult airway and there is a high incidence of obstructive sleep apnea. Coming to the cardiovascular system, these patients have coronary artery disease and congestive heart failure. Respiratory system involvement involves restrictive chest physiology, pulmonary hypertension, hypoxia, and hypercapnia. These patients also have a difficult IV access and difficult position. They also have poor tolerance for hypotension, hypertension, hypoxia, tachycardia, and fluid overload, which all predisposes to cardiac arrest. So, however, the CABD sequence and algorithms remain same in these patients. So, coming to the challenges due to excessive adiposity. So, first challenge is patient assessment and logistics. Then, quality of chest compressions, efficacy of defibrillation, difficult airway management, IV access and efficacy of vasoactive drugs, and transportation and post-ROSC care, that is targeted temperature management. So first and foremost, about the patient assessment and logistics, which generally delay CPR in these patients. These patients cannot lie supine. OSA patients are generally drowsy. Obese patients have a very short neck, which then makes difficult carotid palpation extremely difficult. And monitoring and transport equipment appropriate for weight are also generally not available. So head up is preferred. Spend full 10 seconds to elicit responsiveness. Multiple rescuers must be always present as a code team obese, and they should have equipment adapted to various weight ranges. Next is the quality of chest compressions adequacy issues. So we need a flat, firm surface, and it is not always there available. Point of placement of hands and legs. So is there a role? Then can we push hard, push fast, and ensure complete chest recoil in these patients? What would minimizing interruptions in chest compressions? And what should be the compressor provider characteristics? So first, come to the firm flat surface. So the problems encountered in these patients is that the back boards, they may be difficult to slide because the patients are very heavy. The heavy torso, if we don't use backboards, then the heavy torso sinks into the mattress, leading to less component of compression. There can be mattress displacement. Then about the lateral tilt, this is necessary because the increased intra-abdominal pressure can hamper venous return because of increased visceral fat. So there is this Berry board, which is a bariatric CPR board, which can be utilized. So as we can see, it is raised in the middle. So this creates the use of, this board, it has been designed to create a smaller surface area, which in turn will optimize force. This is an innovative two-plane design, which can support the torso and spine during the CPR compressions in patients weighing more than 125 kgs. This raised surface, due to this raised surface, the sternum is elevated, and we can provide good compressions. Like the spine is placed on this, so there is elevation of the sternum, and there's a hard surface, and hence effective CPR can be performed on this board. So it elevates, as I told, it elevates the sternum, redistributes the adipose tissue, and provides a targeted hard surface to compress against. The next question was the placement of hands. So a study was done by Lee et al., where they tried to compare the optimal point on the sternum for chest compression between normal and obese and normal weight individuals with respect to the BMI using CT. So they found that the optimal point of maximal left ventricular diameter projected onto sternum was slightly more cranial for obese patients. However, when they tried to find out how much is the difference, it was found to be around 20 millimeters. So the range was within 20 millimeters or 2 centimeters of the one that was found in the patients with normal weight. So we need to place the hand slightly higher. Next study was done comparing body mass index and thoracic subcutaneous adipose tissue depth. So they found that there was a thick anterior subcutaneous adipose tissue as well as posterior subcutaneous adipose tissue in obese patients. And because of the presence of this adipose tissue, so the pushing forces that were generated in the skin they got dissipated through this thick thoracic subcutaneous adipose tissue, resulting in reduced effectiveness of CPR in these patients. Another study, which was a retrospective study, they found that high BMI, that is a BMI more than 23.4, and a thoracic anterior-posterior diameter of more than 18.5 centimeter was correlated with worse outcomes. So CPR with physiological monitoring should be the norm in obese patients rather than one-size-fits-all approach. So coronary perfusion pressure can be done, which is related to myocardial blood flow. However, the problem with this is that it is invasive and requires arterial and CVP catheters. So the goal of coronary perfusion pressure is that it should be more than 20 millimeters of mercury. Then the diastolic blood pressure. The diastolic blood pressure, it is a surrogate marker, or it determines our coronary perfusion pressure. And it also requires arterial catheter and invasive monitoring. So in infants, it should always be more than 25. In children, more than 30, and in adults also more than 30. ETCO2 is related to cardiac output and is available in all intubated patients. So ETCO2, our target should be, in 1997, a study was done by Levine, where they said that the ETCO2 should be more than 10 millimeters of mercury. However, in 2015, it was revised to a ETCO2 of more than 20 for an effective CPR. Then cerebral oximetry has been done, but then optimal values are unknown. Next is the cardiac ultrasound, which is being used these days, but then again, it is technically difficult to do in a situation where the patient has arrested and CPR is going on. And for this technique also, there is no standardization yet. So then, hence we need more of feedback devices in these patients. There must be an early rotation of the compressor, high chest compression fraction, and needs excellent teamwork. So manual versus mechanical chest compressions, as we all know, a lot of devices have come up recently. So, but still the use of mechanical resuscitation devices is limited. The slope of anterior chest wall limits its use. Another is the insertion of these devices in obese patients. However, they found that newer devices combining compression, decompression with active compression decompression with impedance threshold device aids active recoil. We can see in this figure that when a conventional CPR was performed, there was a passive recoil. And during this passive recoil, there were minimal change in airway pressure, and which led to a small increase in circulation. Because during the decompression phase, air was sucked in, which increased the intrathoracic pressure. This increased intrathoracic pressure led to decrease in venous return because the pressure was positive. However, when the impedance threshold device was applied, in the second scenario, when there was a ACD with ITD CPR active recoil scenario. So this ITD device, it did not allow much air to enter during the decompression phase, leading to a decrease in airway pressure as compared to the conventional CPR, which then increased the preload and which led to the increase in cardiac output. So another thing that is important in these patients is we should try to perform a slightly head-up CPR, because that leads to a decrease in ICP, and it also leads to an improvement in venous return and return to spontaneous circulation rates. So next question is whether what to do in defibrillation of obese patients. So successful defibrillation requires adequate delivery of transcardiac current, which is dependent on transthoracic impedance. Obesity increases transthoracic impedance and decreases the transcardiac current. Biphasic defibrillation can overcome influence of TTI and may adjust output according to patient's impedance. Adhesive pads should be preferred over paddles. However, will need paddles to compress and reduce the impedance, SAT, that is the anterior pad that offers. AP position is better for defibrillation pad placement with a saline mattress beneath, and consider high energies if initial defibrillation attempts fail. Coming to the difficult airway management, so we know that it is a physiologically and anatomically difficult airway, and there is difficult bag mask ventilation, there is difficult tracheal intubation, even if we need to get a surgical access for airway, that is also difficult. So we can use a lot of agents, we can use para-oxygenation, we can use, we can see HFNO. These patients, if time permits, can be placed in ramp position. We can use video laryngoscopes. So peri-oxygenation and position, multiple experienced providers should be available. We should avoid excessive bag mask ventilation. Early definitive airways necessary. A second generation supraglottic device should always be available as a backup, and oxygenation is the key. So we have to start peri-oxygenation in these patients. Next is breathing and ventilation. So the ratio is same as in other adults. It is 30:2 for bag mask ventilation, or 10 breaths per minute if definitive airways present without synchronization with chest compression. High inspiration pressures are needed due to increased intra-abdominal pressures, and use of EtCO2 is mandated. Next is difficult IV access and efficacy of vasoactive drugs. So peripheral IV access is difficult and it is preferred at antecubital fossa. We must try to use long cannula or catheters. For intraosseous access also, long needles must be available. Intra-arterial catheters are must for all critically ill obese patients. And the drug doses, the vasoactive drug doses are same as for non-obese. So coming to the CPR algorithm, so it is the high quality CPR components are the same. We need to push hard and push fast. So this blends BCLS and ACLS using all elements of excellent team dynamics. Always look for and treat underlying causes simultaneously with high quality CPRs. So post our reversal of spontaneous circulation care. So obesity may worsen post resuscitation syndrome. As induction of hypothermia takes time, studies report poor outcomes in obese patients treated with TT. So coming to the outcomes of CPR in obese patients. So 7 studies were done which involved 25,000 patients. The primary outcome was survival and the secondary outcome was neurological prognosis. So they found that morbid obesity and low BMI were associated with lower survival rate, but the overweight people had a higher survival rate and better neurological recovery, and clinical outcomes did not differ between obese and normal weight. They found this was called as the obesity paradox, where they found that the overweight and obese had a better outcome as compared to underweight and morbidly obese. However, we should not be very happy about it because these patients were younger age, they had a better nutritional status and metabolic reserve. They had a buffering action of increased TNF-alpha receptors, but they were also younger than 7 years younger than their non-obese counterparts and had a higher prevalence of cardiovascular comorbidities. So we should not interpret this rationale as that we must gain weight to avoid cardiac arrest. So coming to the take-home message, anticipate preparation for both out-of-hospital and in-hospital cardiac arrest in obese. High quality hemodynamic directed CPR should be performed by well-trained providers. Physiological monitoring of CPR quality is imperative. Early switch off compressors aided with excellent teamwork. Defibrillation and drug doses stay same as in non-obese. Senior experienced provider for definitive airway access. And many research vistas, simulation trainings, and national registry of in-hospital cardiac arrest in obese are required. Thank you for the question.
I think Dr. Madhvi, the other chairperson, or she's there. Yeah, you can invite the next speaker.
Okay. Good evening, everyone. I would like to welcome Dr. Vivek Gupta, who is consulting cardiac anesthesiologist and intensive care. We all know him as ECMO physician, who is working at present at Daran Medical College Hospital. I know him personally as instructor at Usmania Medical College, Hyderabad 1.5 years ago, as an active and enthusiastic instructor of IRCF and BCLS and CCLS. Since then, we must have trained so many PGs, UGs, super specialty with his active and emotional instruction. With that motto, we have started. I welcome you, sir.
Good evening, all. Thank you, ma'am. Thanks for the kind introduction. Is my screen visible? Is my slides visible?
Yes, sir. Yes, sir. It is visible, sir. Please go ahead, sir.
Thanks a lot, Anju ma'am, for the kind invite. So I'll be talking briefly about ECMO CPR, and I'll try to restrict myself to as simple as possible for better understanding of our juniors and residents. So we all know that sudden cardiac arrest is a complex and life-threatening situation, which really requires a multidisciplinary care to ensure that outcome is better. So there are so many strategies to achieve a return of a spontaneous circulation, and we try to optimize post-resuscitation care. And we know that there are 3 phases of resuscitation when we are doing CPR after the cardiac arrest. Initial phases where we more focus on the electrical therapies on the shockable rhythms. That's electrical phase up to 4 minutes, circulatory phase 4 to 10 minutes, and where we focus more on the high quality CPR along with the shock if it's a shockable rhythm. And finally, it reaches after 10 minutes to a metabolic phase where a lot of metabolic changes. So ECMO as an is unique resource for a selected group of patients, not for all patients, but for a certain selected group of patients who have a persistent cardiac arrest and who are not responding to a conventional CPR, may be a candidate for it. So if we look at these phases, electrical phase where we are focusing on AED distributions, or availability of the defibrillators, early monitoring, and after 5 minutes, we are reaching to a level where we ensure the quality of CPR is a high quality, and we are looking for the metabolic therapy or reperfusion therapies to ensuring any reperfusion and anti-reperfusion therapy to prevent any minimize the risk of injury. But all this is important that we know and we ensure a high quality of CPR. So to make it as ease, I'll take a case, and it's a real case scenario which we did as the first ECMO CPR actually in 2013. So this was a 68-year-old male patient who had a chest pain and diagnosed as a ACS. Otherwise, he was absolutely unremarkable, and a plan of coronary angiography was done. And it turned out to be ostial left main disease with a triple vessel, and an urgent surgery was planned. But you can understand that when there is a tight ostial left main, patient is always at a risk, and we plan for the surgery. He suddenly developed a ventricular fibrillation. At around 11:29, code blue was activated, and a high quality CPR was initiated with the defibrillator, use of defibrillator. Multiple shocks were given, but he did not respond. We quickly talked to the cardiologist and talked about the ECMO support. And almost at 90 minutes since cardiac arrest, with ongoing CPR, family gave the consent. The ECMO team was quickly organized because even we were beginner at that time, and you can see this was a ventricular fibrillation on the monitor. We initiated a VE ECMO using 17 French arterial cannula and 25 French venous access. We were lucky that at that time, cardiologists were doing a femoral access for the angiography. So arterial access was there. We quickly secured the arterial venous access, and we went on ECMO 50 minutes since the cardiac arrest with ongoing CPR. The moment we went on ECMO, we stopped CPR because we were able to maintain the perfusion. We maintained a good amount of flow, and we could see that the VF converted to a very coarse VF. Immediately, patient was taken to the cath lab, and then cardiologist did a balloon dilatation, and finally they placed a stent. Once it was done, we immediately gave a shock, and this produces an organized rhythm of the monitor with the blood pressure so that the heart has started injecting. You can see here, this was the pre-dilatation of the left main artery, and here you can see that the flow has been restored. So we continued with the VE ECMO. We maintained, monitored all hemodynamics, and echo showed around 30% EF with the regional wall. Blood pressure was maintained. Gradually, we reduced the inotropes, and the hemodynamics started improving. Next morning, we did a decannulation, and finally, on day third day, after 72 hours, we extubated this patient. He was a complete recovery without any neurological deficit, and he was discharged from the hospital on day 8. So what exactly is the eCPR? eCPR is an application of VE ECMO, but it is totally different from VE ECMO because you are putting not as an elective procedure, it is an emergent situation where ongoing CPR is taking place. Where we have failed ROS, or we are failed to retain the ROS while undergoing a resuscitation. So ECMO can be used as a bridge to recovery, which is pretty common in these patients, or bridge to any procedure, which can be as we did in our case, or it can be to a long-term bridge. For example, for the cardiac transplant, or for the left ventricular assist devices, or sometimes it is bridge to donation or bridge to decision. Because some patients are, we can procure the organs if the family is willing, or they have already given consent for the organ donation. Or bridge to decision, suppose family is too emotional and at least they get the time to think about it, that what next to be done. So this is what exactly happens when we talk about the peripheral veno-arterial ECMO. We place a long cannula in the femoral vein, blood is taken, it passes through a centrifugal pump, and then it passes through an oxygenator where the gas exchange takes place because we are connecting an oxygen line. You can see the green tubing here. Connected with this, we can adjust the flow. And finally, the oxygenated blood is returned back to the femoral artery. And you can see here, it will go and it will maintain the perfusion. This is what exactly was the patient. We had this, you can see this is the arterial cannula. The medial one is the venous cannula. And you can see here 7 French cannula. This is the distal perfusion cannula because the wide bore cannula is the femoral artery. So we are maintaining the distal perfusion to prevent any ischemia to the distal limb. So what is the rationale? Why we should do? Because we know that even it's an in-hospital cardiac arrest or out-of-hospital cardiac arrest, the survival chances are pretty low. Slightly better in hospital cardiac arrest. And even conventional CPR, when we perform with the best of our chest compression, we just maintain 30% of the cardiac output. And that depends, the survival depends on so many factors, the underlying condition of the patient. So when we put this patient on ECMO, this enhances the chances of myocardial recovery. It basically, we don't need to achieve a ROS. Even there is no rhythm, if there's a flat line, if there's a ventricular fibrillation, doesn't matter because it is going to maintain the perfusion. And any intervention required during this, we can do, including the coronary intervention. And definitely we can reduce the risk of neurological injury because we are maintaining the perfusion. If you look at the data of the ELSO, which is an organization which collects the data across the world, in 2019, there were just 2,000 cases for adult ECMO CPRs. Though survival was looking 42%. In 2022, it was 12,000 increase, but the survival is just 30%. And in 2024, which was just published in the last month, it is 21,000 and survival was nearly same 31%. We can understand the survival in these patients are multifactorial, and so we don't expect a very good survival for these patients. So what the benefit? We promptly restore the circulation. We allow performing any procedure, radiological investigations are definitive surgical or percutaneous treatment. We can even provide the therapeutic hypothermia if patient requires that. We can prevent other organ damage because we are maintaining a good perfusion of the other organ, including liver, kidney, brain, everywhere. And definitely when we are maintaining the peripheral perfusion, it means if the patient doesn't survive, he can be a candidate for an organ donor. So which patient to be considered? So far, we do not have a clear-cut guidelines or criteria, though ELSO has done some work, our other organizations have done some work, but still we don't know. But definitely when we are planning to do a ECMO CPR in any patient, the first thing should come in our mind that reversibility. Is it the condition is reversible? It's a sudden cardiac arrest. If the initial rhythm is ventricular fibrillation or ventricular tachycardia, is shockable, the chances of survival are much, much better. If it is a witnessed cardiac arrest, because if it is unwitnessed, you don't know how much damage has occurred because of the no perfusion situation. If the no flow time is less than 5 minutes, chances are better. Low flow time means ongoing CPR time. It depends upon quality of CPR and time both. So if you have a high quality of CPR, even up to 1 hour of CPR, you can have a good neurological outcome. So monitoring quality of CPR, looking at ETCO2, or if there's a arterial line, looking at the diastolic blood pressure, definitely should be taken in consideration while deciding about the ECMO in any of these patients. But what is important, you rule out every contraindication, which includes the contraindication for anticoagulation, any major neurological surgery or intracranial hemorrhage patient had, or age is above 70, though it is a relative contraindication, but that should always be taken in consideration in these situations. Any terminal illness or aortic dissection or end-stage hepatic failure or even renal failure, these patients may not be a good candidate for ECMO. So how to approach? One should continue with the high-quality CPR, that's the crux of that. Quickly evaluate the patient whether he's eligible for it, and we have to quickly activate the team because it is going to take at least 20 minutes to arrange everything, even in the good centers, and priming the circuit, that's the most important. Do counsel the patient's attendant and take a consent for it. The team should ensure through the checklist and quickly communicates and ensures that the ECMO card is ready. ECMO card is like a card, as we talked about the crash card or code card in case of cardiac arrest. A console with the DCM the unit should be ready. All consumables should be available and everything should be an extra because it is possible in an emergency situation, your needle is falling, wires are falling. So those things should be available in plenty so that nobody is running during that time. And all infusion should be there, circuit should be primed, and any other thing should be discussed right up there. So what are the different stages that comes? The first thing, you should ensure the access. You should at least have some sheath in the femoral artery and femoral vein before placing the cannula. And that should be unobstructed flow because these cannulas are very thick. And if you don't do it thoroughly, probably you may injure the vessel and the whole thing will go because you can't. If you can't cannulate, you cannot go on it. Then once you are sure about your placement of the wires, you place your ECMO cannula or using the Seldinger technique, and then you can, once the circuit is primed, you can initiate the ECMO in these patients. The cannulation usually is peripheral. Central can be opted, but for that you need to do sternotomy and surgeon should be ready. Peripheral, anybody can do who is trained for placing the lines in these situations. So ideally, there should be 2 physicians that should run the code. One should the cardiac code, means cardiac arrest code, who is doing resuscitation, not looking at the other side. And the second team is the ECMO team who is placing the line and ensuring that they have the ultrasound probe with in a sterile glove so that it is you are maintaining the sterility. And once it is done, cannulation is done, then that can be available for the other team members for the diagnostic purpose. Usually, both in-hospital and out-of-hospital cardiac arrest has been reported, but usually one should start with the in-hospital cardiac arrest because you should have experienced team, ECMO system should be ready, which is difficult in our country or in our situation, but the time schedule usually a rough time, a decision, pro and con debate for it to do or not to do 10 to 15 minutes. Once the team has arrived, 15 to 25 minutes, and once the team has reached, by 35 minutes, we should be on it. Use Seldiger's technique for cannulation because surgical exposure may be taking time, and do not expect a much survival. 30% is a good survival. If the patient is aged, renal failure, or pre-ECMO pH is very low, or some other issues are there, then definitely chances of survival may be less. Remember, ECMO is not a treatment. It's just you are supporting the circulation, so a definitive strategy must be in the mind while deciding. This is difference the in-hospital and out-of-hospital. So in-hospital, if so you are transporting the patient, you are wasting time. So people have tried to do ECMO in the field itself to reduce the time, reduce the flow time. Once you have done the cannulation and you have gone on ECMO, a decision has to be made. If the patient is not having convulsion, fibrillation is persistent, then better to bring the patient to a cath lab. That's a priority to ensure a flow to the coronaries. If the patient is otherwise fine, you can do a CT scan to rule out any intracranial hemorrhage. But make sure that you have adequate flow. If there is no adequate flow, that means your ECMO is not working, some cannulas issues are there, and that needs to be addressed. Once the spontaneous circulation has returned, means you have achieved the flow with the ECMO, then you can manage arrhythmia again with the pharmacological defibrillation, and you can establish a coronary reperfusion. But if there is a PEA or asystole, that means your LV can distend, and that you should keep in mind that myocardial contractility is important in these patients. Otherwise, there can be clot in the LV itself. So that needs to be addressed. Targeted temperature, if there's a long time of sleep. What are the barriers? Team composition, difficult in our situation. Team availability, bit difficult. Indication list should be clear, and one should have an ethical discussion. At least one should always talk about ECMO nowhere situation when the patient is not recovering, what to do next. That family should be taken in confidence. The challenges, where to do, how much no flow time, how much slow flow time, what was the quality of CPR throughout the course when we are placing the ECMO, and how much people are trained who are doing the ECMO, or what are the indication, when the decision was made, technical issues, cost issue, and ethical issue. 3 trials, I'll just quickly say, these are 3 large trials has been done. One is the ARREST trial, one is the PROG trial, and in
Dr. Vivek, unmute yourself.
Yeah. So ARREST trial has shown us a good survival. Other 2 trials have not gone in so good results. But if we look into this, the category of the patient selected probably was different than the ARREST trial. So definitely for selected group of patient, it will really be good to go for ECMO CPR, where we can have a good survival. So these are some papers which have shown a good results. Here they had the 56% of survival when we did the early reperfusion after doing the mechanical CPR, means ECMO CPR. This was a single center trial. But unfortunately, we still do not have any guidelines or recommendations by European Resuscitation Council or American Heart Association. Up to 2019, they did not have any much of the evidence. But in 2024 update, they have written just that they are acknowledging eCPR as a specialized technique in certain situations, but still they are not including it in their guidelines. Even also do not have any separate eCPR guideline. They are just have talked about the technical issues related to it. So there are some pro criteria and contraindications. Pro criteria, when we have observed cardiac arrest, no flow time is less, short low flow time of CPR, and we know the reversible cause is there. But if the age is above 70, non-observed cardiac arrest or no flow time is longer, then we should avoid doing CPR in this situation. How do we establish an ECMO program? This is very important. A team should be created who is good in the CPR. The first, you should have a CPR training programs and good CPR program, and then you should have some experience of the ECMO then you should think of doing eCPR in your system, because that requires a lot of skills and coordinated action. You need a multidisciplinary team, and you should have a protocol, you should have a equipment, and definitely you should have an administrative support. Without that, probably it becomes very difficult. But in our countries or in our scenario, definitely there's a poor awareness and training of CPR. That means we have a long no flow time and no flow time. So we do not have an organized system for ECMO infrastructure. We don't prime our ECMO circuits because of the cost issue or so many other issues. Teams are not well trained. We do not have much of the protocolized approach, but we are trying to make it, and probably we are able to do it. In last 10 years, we have done more than 10 ECMO CPRs with a good survival. And moreover, the lack of awareness probably one of the biggest challenges in these patients, including the cost. So to conclude, there should be a team-based approach. Everyone should know their job. We should have a patient-centered resuscitation where we are monitoring ETCO2, we are looking at the diastolic blood pressure, we look at how much was the intra-arrest time, and the line person who is putting line should be capable enough to place this line. And what is important, we should be mentally prepared, because rest all can be done if we are having a speedy decision, yes or no, and if yes, we should immediately start giving up. We should start working on and never give up in this. Thank you very much. If you have any question, I'll be happy to answer.
I think let's go ahead with the last talk of today's session, and maybe then we can have questions at the end of the session. So, so Dr. Devyani can introduce the last speaker.
Yeah. Happy to do that. Very good evening. I'm highly thankful to Dr. Naveen sir, Dr. Anju ma'am, and Dr. Vishal for making me the part of this very important, nice webinar. And I'm highly privileged to introduce Dr. Anju Garewal ma'am. She doesn't need any introduction. Still, madam, I'm very happy that you are an inspiration to so many people, including me. So very happy to introduce you. She is the head AIIMS Bathinda, and she is also working as editor-in-chief anesthesia tutorial of the week published by the WFSA. She is national president of AOA as well as the president-elect RSSCP, and she's also remained associate editor as International Journal of the Regional Anesthesia. Ma'am, all the stage is yours.
I need to. Am I audible to all of you?
Yeah, ma'am.
Yes, ma'am, please.
Thank you so much, Dr. Devyani, for such a generous introduction. So at the very outset, I thank the entire team of RSA for giving us this opportunity to speak to you on the special considerations in the unique group of patients. So I will be talking in the next, I'll take maybe a 5 minute more, 15 minutes on maternal CPR, the pitfalls and pearls. So I bring you greetings from AIIMS Bathinda, where I work currently. So my lecture objectives will be, I'll take you through the AOA India guidelines. Association of Obstetric Anesthesiology works closely with RSA, and we have evolved our guidelines, which were published in 2022 and are free for everybody to access online. And then we'll look at the pitfalls and, of course, the pearls for successful outcome. Now, why are we talking about this? We need to understand that every day, approximately 800 women die from preventable causes related to childbirth and pregnancy, meaning that a woman dies every 2 minutes. And by the end of my talk, at least 8 to 10 women would be dead, right? And there are 2 lives at stake. Parturients are young and healthy. And despite that, what was seen was that survival rates were poor, and hence there was a momentum to increase the awareness of how to go about resuscitating these mothers. And therefore, a rigorous training showed that the data for survival to discharge did increase to 58%. So that means that we really need to upskill ourselves first and foremost to know what the guidelines are, what are our pitfalls, make ourselves cognitively aware of what the underlying issues are and how do we go about resuscitating these mothers. And then, of course, upskill ourselves into the skills of CPR. So this is the guideline that I was talking, which has come from the Association of Obstetric Anesthesiologists. It's a consensus statement which has been published in 2022. So as I take you through, the beautiful part of this guideline is that we have a very descriptive infographic, which has been made by our team, especially Dr. Ketan Parekh, and of course with the entire team of authors. And this is actually very important because in a high-stake environment where there are two lives on board, there's a huge emotional load along with cognitive load. This kind of thing, an infographic acts like a cognitive aid to tell us what is important and on what priorities should we go about. So if you look at the priorities, as soon as you find that a mother or a pregnant mother has become unresponsive, she has an absent carotid pulse and is either gasping or is not breathing. So all the three ingredients are there, which will tell us that she has gone into a cardiac arrest, is the time where you really need to think of the 3 Fs. That is, I need to initiate chest compressions as fast as possible and make them as high quality as possible. So that for that, I need manual left uterine displacement of the uterus, especially if the uterus is above the umbilicus, that's beyond 20 weeks of pregnancy. Really need to focus very fast from the very beginning onto why is my mother into cardiac arrest, and therefore we have a very easy mnemonic from the AOA which says A, B, C, D, E, UPS. There are multiple mnemonics in literature, but we try to make it as simple as possible to reduce the cognitive load on the provider. Right? And then at the very time of cardiac arrest, we really need to start to think about resuscitative uterine interventions. Why? We will look at it as we talk along. Yeah. So as we all know, as soon as we find somebody is in cardiac arrest, we shout for help. The important thing here is that we are going to note the time and we're going to activate an emergency team. And the emergency team that we are going to talk about is basically a maternal code blue team. Now, why do we need a maternal code blue team? Is because we need also to empty the uterus as we are doing a high quality CPR. Okay. So one of the most important cornerstones of high quality CPR is to think about causes at the very outset of cardiac arrest as you start a CPR, a chest compression. So you work simultaneously and you start thinking about all these ABCDs, UPS, and is my mother into cardiac arrest? One of the very good ways is to assign a person to talk to the nurse if the patient is an in-hospital parturient, or to the patient's attendant to understand what has gone wrong, which has led to these causes. Is it anaphylaxis? Is she bleeding? Does she have an underlying severe mitral stenosis? Has she been given some drugs? Is she on magnesium sulfate especially? Is there been some incidence of amniotic or pulmonary embolism? The mothers are pretty predisposed to that. We also need to look at uterine causes. She might have delivered and there's still a placenta sitting inside and she's bleeding up there, or there is an abnormal placentation which has led to a bleed. And of course, pulmonary and septic causes, which are again very rampant in our country. So that's very, very important. And then one important thing that I really want to emphasize is that our labor floor should have the same kind of emergency carts as are there in the non-labor floor areas. That makes the provider more, in sync with where these things are, and therefore you do not waste time resuscitating these mothers. And then, of course, as I said, while you're thinking what your causes could be, you're assimilating your team. You start off with basic life support and blend it very well with advanced life support. So there are certain peculiarities that I'm going to highlight. I'm not going to take you through the entire BLS and the CCLS or the ACLS guidelines. But for the mother, it's important that the first member who witnesses a mother who has arrested or has been, brought to the casualty where a mother has just arrived with a cardiac arrest will actually go about assessing scene safety, checking responsiveness, asking for help, and then check pulse and breathing to confirm that the cardiac arrest is indeed there, and starts off with high quality chest compressions. If there is a firm backbone, you can use it. The more important thing is the person who responds will actually go ahead and activate the maternal code blue team. Now, what is a maternal code blue team? It's a team that comprises of a regular code blue team of your hospital. In addition, there is an obstetrician on the floor who is on call for this, an anesthesiologist and a neonatologist. And this member also notes the time. And then, of course, gets the crash cart and attaches the defibrillator and becomes the guy who will be working on the defibrillator. So you're also allocating roles. So we have one person on chest compressions, another on defibrillation, after activating the maternal code blue team. And very important that we catch hold of some person who would do continuous manual left uterine displacement as the CPR is in progress. And of course, because these mothers, we all would later on understand that these mothers have unique physiological issues, and hence oxygenation is also equally important. And therefore, we need to pick up our ambu bags or our second generation LMA, shove them in and start to administer 100% oxygen. So this is what we go about it. But then as we are going about it, we need to remember that in a non-pregnant person, when you do a high quality CPR, all that you generate is 35% of the cardiac output. And in a mother who is pregnant, and especially beyond 20 weeks, this pregnant uterus is sitting over the aorta and the inferior vena cava, and hence is not allowing any preload to come in and neither any uteroplacental circulation to occur. So in this particular case, the quality of your chest compressions will be solely dependent upon the efficacy of the manual left uterine displacement that you have put in place. And hence this provider who picks up the uterus, goes onto the left side of the mother, picks up the uterus upwards and then leftwards, and then sits down with the uterus manually tilted. So that is very, very important all throughout the chest compressions. If there are too many people on the right side, the provider can also go on the left side, and too many people on the left side, then the provider can go on the right side and also push. But what has been found that the pushing of the uterus is inferior to the above technique where you lift the uterus and take it to the left-hand side. This is an important maneuver that is extremely important for these mothers. What you really need to understand is that the lateral tilt or those wedges are not indicated because they will result, one, in a less force of chest compressions, and also there is still evidence of aortic compression even at 30 degrees of left lateral tilt, right? And as I said, advanced airway management is extremely important, and that is why your anesthesiologist is part of the maternal code blue team. And because these mothers are going to desaturate, they're physiologically as well as anatomically difficult, we really need to limit our intubation attempts. Do not get into a fixation error of putting the tube across. Use an early rescue with a second generation supraglottic device. In my previous institute at the Anand Medical College, we did an audit for such pregnant mothers. It has also been published in the Journal of Obstetric Anesthesia and Critical Care. And we found that replacing the endotracheal tube with a supraglottic device, the second generation, really made a difference because even the nurses were trained to put in, and that really caused good oxygenation in these mothers. So that is what is important. And however, if you're still not getting a good, chest rise with a second generation supraglottic device, please have a low threshold for front of neck access. It is imperative that we really upgrade our labor floors and we institute and we ask for a continuous waveform capnography in our monitors so that we can not only monitor the correct placement of our endotracheal tube, but also monitor the quality of our chest compressions, right? So it is important that in these mothers, some method of monitoring the quality of chest compressions is always to be taken in. Now, what I really want to tell you, and for want of time, I had to remove that slide, but it is important for all to remember that the hand position does not change in pregnant mothers. And so does the defibrillation doses. So the thoracic impedance does not change. Fetal monitors, if attached, can be either removed or they can be kept around because they do not cause any harm to the fetus when you deliver the regular defibrillation doses to the mother. A wide bore IV access needs to be established above the diaphragm. So that means that if you do not have a good wide bore IV access, then you need to go in for an intraosseous access, especially on the upper humeral head. So that is very, very important up here. The doses of drugs, that is epinephrine, and if it's a shockable rhythm, a ventricular fibrillation, which is not responding to shocks, and you need amiodarone, they would stay the same as we would be giving in a non-pregnant patient. What is more important that we always think about, why is my mother in cardiac arrest? And simultaneously, while doing a high quality CPR, start treating the underlying cause. But despite all these efforts, the mothers are not going to get revived very fast unless resuscitative uterine interventions come into place. Now, previously, we would call this as perimortem cesarean delivery. So there was a big emotional embargo on our minds that, it is perimortem, so why should we do it? And then the SOAP and the international guidelines changed the nomenclature to resuscitative hysterectomy, and the AOA changed it to resuscitative uterine interventions, meaning thereby it is part of CPR, and therefore it needs to be done as soon as the mother gets into cardiac arrest. So we start thinking at that point in time. We have noted the time, we called the maternal code blue team, and now that team is going to simultaneously start preparing so that by the 5th minute, we are able to deliver the baby. What is important for us to know that we do not move this mother. We do it at the site of cardiac arrest with the CPR going, and scalpel is perhaps the only essential equipment with maybe some green Armitage forceps that you might need, right? So as soon as there is an evacuation of the uterus, there is a high chance of getting return of spontaneous circulation. These mothers would get revived, and once they get revived is the time where you would shift them to the operating room to, maybe she might get into bleeding, she might have PPH. So that is the time you will, do your further surgical steps, and of course, look for securing all the bleeders up there. Oxytocin can cause rearrest, and therefore the drug of choices here in cardiac arrest is methergin or prostaglandins, and we must have a low threshold for uterine compression sutures. So that means that we really need to be talking to our obstetric colleagues as we are resuscitating these mothers. Once they have been resuscitated, post-resuscitation care in ICU is paramount, and they can be given mild hypothermia. What is important is that I'm really happy that Dr. Vivek came in and talked about ECMO CPR. Mothers, especially those who have recurrent cardiac arrest, there is an underlying cause, or there is a local anesthetic systemic toxicity or an epidural on board and it went intravenous, are kind of candidates which can be given ECMO CPR, and there have been good results into that. So what are the pitfalls, having talked all about the guidelines? The main thing is that what has been found is knowledge deficits are there. Then, of course, there are poor resuscitation skill. But above and all of them is lack of teamwork and situational awareness. More often than not, we are lost in the melee of chaos that comes in. And then compound to that is poor understanding of physiological changes of pregnancy. And hence, we fail to recognize clinical deterioration many a times in our labor floors. And this delay is actually pretty lethal to the mother. So all these factors, especially the hesitation or the fear to start a timely PMCD, which has now been renamed as resuscitative uterine interventions, moving the mother to the OR to deliver the baby, taking a consent, moving up and down and forth, and not doing a manual left uterine displacement. All of these are kind of, pitfalls that really, hinder the good survival of these young mothers. And to top it out, the icing on the cake is that, unfortunately, we are still not trained into human factors. We do not have situational awareness. We get overloaded with the cognitive and emotional load. And then with poor communication and teamwork skills, with fixation errors, which is a perfect recipe for disaster. So that is where we need to focus our trainings into. So what are the pearls? As I have talked about pitfalls, very important that we become champions and leaders as anesthesiologists in maternal arrest. We have to ensure that in our setups, wherever we work, whether it's a small setup or it's a tertiary care, there is readiness in our all floors wherever pregnant mothers are going to arrive. Right? And there has to be a mechanism of recognition and prevention of cardiac arrest. If it does occur, an appropriate coordinated orchestrated response. And then, of course, please do, document the arrest, what you did, and then have a system of audit reporting and systems learning so that we can improve the next time. So as I talked about prevention of arrest, this is an article that came recently in the ATOTW. And what is very easily needed is introduction of maternity early warning scores. These are simple scores. All that your nurses are to be trained is now they are going to put their vitals, the respiratory rate, the SpO2, the temperature, the pulse, the systolic and the diastolic blood pressure in a colored chart. And they know that if the mother has moved from a white zone to a yellow, or she has a red flag, it's a time that we really need to call the RRT team and, escalate our care and prevent the arrest. We should know why this mother has gone into cardiac arrest. We should also take help of these risk prediction tools, of our high risk mothers, especially in today's times where we have a multitude of preeclamptic mothers, seizing mothers, bleeding mothers, mothers with placenta accreta spectrum coming to us. We should be able to, have some kind of risk prediction on arrival. Having said that, it is important to inculcate simple measures. Put your pregnant mothers in left lateral position. I often tell my obstetricians, if you're shifting your category 1 cesarean section and I see that mother supine, they've always are a kind of educator or sometimes even told then purpose of doing a section is lost. So it's very important that all our mothers beyond 20 weeks be in left lateral position. If they are getting sick, if there are red flags, administer them 100% oxygen by whatever oxygen delivery devices are available, but they should be available. Establish a wide bore IV access above the level of the diaphragm, and do have some kind of an appreciation tactics in your hospital to nurses who would put in green, yellow, orange or gray cannulas and not the ones who put those small pink cannulas. Treat hypotension early. Remember that your values would have changed in a pregnant mother. She would be tachycardic. She would have different normal parameters, and that should be known to you. And of course, we really need to be on a lookout for reversible causes. Very important, and one of the causes, as I told you, about drugs, magnesium, and also about labor epidurals, is to have structured bedside handovers, especially when your mother moves from labor floors to ORs to ICUs. And more often than not, we have had tubings getting interchanged with the magnesium going to epidural and the epidural infusion going to an IV. So it's important that we use structured tools to do handovers and use closed loop communication. Be aware of the physiological adaptations of pregnancy and the pregnancy specific pathologies. And therefore, why is it important? So that we can alter our algorithms according to the physiological changes. And needless to say is team dynamics, leadership, task allocation, all of these are essential to a good outcome, right? So just to give you the students an overview of what the physiological changes I kept talking about, you have to remember that the aortocaval compression can decrease the cardiac output by 30 to 50% in a non-arrested mother. There is an increased oxygen demand. Our mothers are usually anemic. And in addition, there is a decrease in the functional residual capacity as the pregnancy progresses, which leads to poor oxygen reserves. We all know progesterone causes airway edema, mucosal edema, which makes a mother difficult airway. And of course, there is also an increased risk of aspiration because the lower esophageal sphincter gets incompetent. So all of this makes CPR ineffective, and hence we really need to focus on high quality CPR with manual left uterine displacement and calling the maternal code blue team, which will come and empty the uterus in less than 5 minutes of cardiac arrest. Think early about causes of cardiac arrest and start treating them as early as possible as you are doing your CPR. And of course, always have a definitive airway as early as possible. So if you combine all of these with team dynamics and have good cognitive aids in the form of algorithms printed and put on your crash cards, they will help you to think correct. What helps you more is a multidisciplinary team training, mock drills, and of course, through debriefing, not only after mock drills, but after true maternal cardiac arrest CPRs as well. Because we really need to, get our teams online to be doing a next attempt much more efficiently and saving more lives. So in the end, prevent a cardiac arrest if possible. Know your physiological changes. Know your normal parameters in a pregnant mother. Know that there will be changes occurring each trimester. If there is a cardiac arrest, please diagnose it as early as possible and document the time of arrest. We need to evacuate the uterus after 5 minutes. Hence, documenting the time is extremely important. Call for a multidisciplinary maternal code blue, which encompasses an obstetrician, a neonatologist, and an anesthesiologist, also in addition to the regular code blue team. Start with high quality CPR and always institute manual left uterine displacement, without which the quality of CPR will not be better, and use as many devices as you can to monitor the quality of your CPR. If you do not have these devices which monitor the quality of CPR, you can have a person who acts as a coach and stands in front of the compressor to look at the depth, the rate, and the compression interruptions that you are doing. Very, very important to remember that out of the total duration of your CPR, you should be compressing with manual left uterine displacement for more than 80% of the time, and also evacuating the uterus as early as possible. So these are the clues to having, mother resuscitating very well. And with this, I take this opportunity to invite all of you to Indore. So we have the next 2026 conference at 34th Annual National and the 5th International Conference of the Research Society of Anesthesiology. And we look forward to, hosting you all there with good academics and a very good Indore hospitality. Thank you so much for the patient hearing.
Madam, that was a very nice deliberation, elaborating all the important steps in the management of the maternal CPR and emphasizing the team dynamics and the multidisciplinary approach as well. I think at the end of the presentation, we can go ahead with the question answers.
Yeah.
Ma'am, I just want to ask one thing. Any experience of vomiting and aspiration when you are using supraglottic devices instead of intubation in these maternal cardiac arrest patients?
So as of now, there are not enough data. Remember that you have to understand two things. In maternal cardiac arrest, life is more important than your lung.
Right.
So even if she aspirates and we can still treat that. But if we lose her, we have lost her. Right? So that fixation error to put an endotracheal tube has killed more patients than saved. And with the second generation endotracheal tube, we are pretty good to go.
Pretty good for that. Yes.
There are a few questions out there. I think. Dr. Vivek would like to take this. Vasopressin was dropped from CPR guidelines despite that it didn't increase the myocardial oxygen demand. Dr. Vivek, you'll have to unmute yourself.
Yeah, I have already answered the question. We had asked, two questions were asked. What is difference between the veno arterial ECMO and on pump when we do for CABG procedure? First thing, usually we do not do CABGs nowadays on pump. It is usually off pump, but if at all we do, it is cardiopulmonary bypass. And there is a lot of technical differences in cardiopulmonary bypass and veno arterial ECMO. For cardiopulmonary bypass, we need to do sternotomy. We have to do a central cannulation, cannulating aorta, as well as to the right atrium, venous axis. Whereas for this VECMO, we do go with the peripheral cannulation. So you don't need to bring the patient into the operation theater. You can go ahead in the ICU. You just use the femoral artery and femoral vein for cannulation. And basic mechanism is a bit different if we say femoral veno arterial ECMO, because this is the opposite flow to the cardiac circulation. Heart is ejecting and we are pushing the blood from the opposite side. So this we always need to keep in mind, because that leads to upper body hypoxemia in a situation when lungs are bad. So these are, and you need to give less heparin here because we are not using any reservoir. We usually use the centrifugal pump, not the roller pump, which we use commonly for the cardiopulmonary bypass. So these are few technical differences. Besides, there's a lot more differences between the cardiopulmonary bypass and the veno. I think I'm clear. If you have any question, please unmute and you can always ask. Another question was there, what is the maximum duration for which we can keep the patient on ECMO post cardiac arrest? So see, it all depends on the reversibility. When the primary cause is reversed, it means the heart has to recover. But sometime in certain situation when the heart takes a bit longer. So usually up to 8 to 10 days with the VECMO, usually there is no problem. But if the time is extending, then you will have a problems associated with the long-term VECMO. That includes a bleeding risk, thrombocytopenia, even hemorrhage on any of the sides. So if it is exceeding 2 weeks, then definitely and patient's heart is not recovering, LV dysfunction is still severe. In those situations, we can switch over to the long-term assist devices like a left ventricular assist device, or sometimes patients can be a candidate for cardiac transplant. So this you have to plan by 7th, 8th day. You know that if it is not recovering, then you can plan for that. If any other question, please, I'll be happy.
Some questions. I think Gigal has answered a few questions on traumatic cardiac arrest. Yeah.
Yes, regarding the use of adrenaline in traumatic cardiac arrest, as we all know, the most common cause in TCA is hemorrhage or the obstructive shock with cardiac tamponade or tension pneumonia. So giving little or no circulating blood volume and giving epinephrine, it has nothing to squeeze from the heart. So it will even worsen. So there is no role of adrenaline or chest compressions before ruling out the reversible cause. So in TCA, the guidelines, European Council of Resuscitation guidelines say that you have to first treat the hemorrhage or the cardiac tamponade or tension pneumothorax, and then you go ahead with the routine ACLS and BLS algorithms. And the second
Can I
question.
add up here? Yeah, just a minute. I just wanted to add up here is that we have to understand that in this particular scenario, we're talking about severe traumatic cardiac arrest, where we have either a severe penetrating chest trauma or a major vessel injury, where there has been a total depletion or exsanguination of patient. So in this particular scenario, what the guidelines talk is actually addressing the underlying cause on priority as you begin starting your CPR. So that takes priority over other attempts. We cannot beat an empty horse. That's what they basically need. Or a tired horse. Yeah. Go ahead, Gigal here.
Yes. And regarding second question, the difference between RIBOA and the IABP. RIBOA, it actually is resuscitative endovascular balloon occlusion of the aorta, and it is useful in the TCA, that is traumatic cardiac arrest. It acts as an internal cross clamp, and it wherever the balloon will inflate, it will act as an cross clamp, and the bleeding below that will stop. And so it acts as a temporary resuscitator, whereas IABP, it is intra-aortic balloon pump, and it acts as a mechanical circulatory support device for severe LV dysfunction or the cardiogenic shock, or as a bridge to the permanent rescue technique. So it actually, the balloon inflates to increase the coronary perfusion, and it deflates to decrease the LV afterload. So the RIBOA, it is useful in traumatic cardiac arrest, whereas IBP has no role in the traumatic cardiac arrest.
Okay, and there is also a role of RIBOA, just to mention that in severely bleeding patients, of course, I'm not talking about maternal cardiac arrest. I'm talking about mothers who are profusely bleeding, where they have severe placenta percreta, and the obstetrician is unable to get hold of the bleeders. So it gives you a transient bridge for that particular point in time where you will put in that compression. You can even do a manual compression of the aorta infrarenally to stop the bleed, and the collaterals would stop, and gives you time to resuscitate. So these are kind of interim measures which help you, during resuscitation process.
Yes, ma'am.
So RIBOA would be useful when there are lower pelvic or lower limb bleeds. That is something that we really need to remember here. Any other question, Dr. Devyani and Dr. Shelley, if you feel that we haven't answered? Dr. Navne is also there. I think there were a few questions on obesity.
The last question also.
Yes, ma'am. Like to ask that, can the board used for obese patients to increase venous return can be used in maternal cardiac arrest too? So though there has not been any reports of the use of Barry board, particularly for maternal CPR, but I think it can be used in these patients also. However, it doesn't replace the use of like the significance of left uterine displacement in relieving aortocaval compression in these patients.
More important thing is to put a manual left uterine distance.
Yes.
There were some issues about. I think Navneet, you'll have to mute yourself. Some echo there. Yeah. Some issues about, I know there are legal issues about, reviving taking the baby out, doing a perimortem cesarean delivery. We have to remember that the law protects you because at this point in time, this resuscitative uterine interventions, which takes out the baby, is part of CPR. You're evacuating the uterus. And also remember that the baby is anyway not going to benefit from staying inside. It is in an anoxic environment. So delivering the baby also helps you to hand it over to the neonatologist who would now start to resuscitate it. But the basic purpose of doing a perimortem cesarean delivery or a resuscitative uterine intervention is for the benefit of mother.
Ma'am, but
And
it's
there is
very
a-
difficult, ma'am, it's very difficult to convince obstetricians, ma'am, to do perimortem. Once if cardiac arrest occurred, means they don't like to do any perimortem because they're very scared that any issue, maternal mortality issue, they have to answer. They're answerable to so many people. That's why
So-
what I feel is each and every person, every obstetrician, gynecologist, not only that, ma'am, every faculty should train in CPR, ma'am, first. Then they'll understand the.
I would like to invite
Importance.
you to our, we do run an obstetric emergencies module from AOA and also in coordination with RSA. And we train and we actually, encourage participation of obstetricians. So get your obstetricians to the training programs where they have their own peers talking to them. We have obstetricians who talk to them about the importance of perimortem cesarean delivery to take off their fears. And then, of course, take them as part of mock drills. Do a lot of mock drills into your labor floors, into your various part of your hospitals. This is only the way to work in these high stakes environment, because what we often forget is that team dynamics take a back seat, and that is what leads to, and as you very rightly said, yes, they have fears. We have to, educate them, train them to get them out of their fears.
Yes, ma'am. Thank you.
So there is a question, ma'am. How much ECMO treatment cost? So it varies from institute to institute. That how much? But usually the cannula which we are placing, this percutaneous cannula costs roughly 25,000 rupees. ECMO circuit costs around 1.95 lakh, and other small things cost roughly 10-15,000 rupees. So you can always initiate ECMO roughly in 2.5 lakh. To begin with, and rest all depends that how much your investigation, because during ECMO run you go for ACTs frequently, then you do blood gases. So those things will be an additional expenditure. Otherwise, ECMO run itself will not have any extra until there's a call.
How can we start CPR in penetrating chest trauma where there'll be a time lag between treating the condition and reviving the patient with CPR?
So here, basically, you have to start with the immediate correction of the cause, like finger thoracotomy or the chest decompression or the hemorrhage control. That takes priority over the chest compressions. That is the crux of the TCA guidelines, because that will not help you. So therefore, chest compressions are de-emphasized in this TCA. First, you have to rule out the reversible cause, because that can be reversed and you can treat the patient if it is less than 15 minutes of the cardiac arrest.
Another thing I would like to add here is that once there is a penetrating chest trauma, I think it's a good form of TCA in the sense that you have access, you can actually create an access to the heart and to internal cardiac internal cardiac massage as you are doing a resuscitative thoracotomy. Of course, it needs a lot of training. It needs it's a high stake environment, and you really need to be ready to know what your roles are. That is very important to clear. Dr. Mayank has raised his hand. Dr. Mayank.
Madam, I just wanted to have a small input into this. If suppose there is a pregnant lady and she is driving a vehicle and there is she's not wearing a belt and the entire thrust comes directly into her chest and the baby is still there and it's a full term pregnancy, then what should be the actions taken in order to prevent the life of first mother followed by the baby?
So now that you know that she has maybe a, an obstructive type of a cardiac arrest, there could be some kind of a tamponade to the heart because there has been a blunt trauma chest to the mother, right? So of course, we would start off with
Right.
putting, chest tubes and starting chest compressions with manual left uterine displacement. But having said that, you need to activate the cord luteum and evacuate her uterus also simultaneously as you are treating the underlying cause. So both the things now need to go in together.
Going
I
together.
would,
Right.
yeah. Are there
Right.
any other inputs from other faculty? I'd love to have them.
Having ultrasound in this situation will be a life saving because you can quickly differentiate whether it's a cardiac tamponade or it's actually a hemothorax. So you will decide quickly that whether you are going to put a needle in the pericardium or you are going to put a needle on the chest. That will be life-saving.
Subxiphoid focus is extremely life-saving.
Yeah. Extremely life-saving. And but will we be able to get a good view with a full-term pregnancy in a subxiphoid view?
At least we can have an idea that if there is a massive collection around the heart, it will you will easily get it.
Right, Dr. Vivek, sir. Right. Thank you, madam. Thank you, sir.
I believe most of the questions have been answered. If there are any questions, you all can raise your hand and we can answer your questions. There was a question, Dr. Vivek. I think you must have answered it. How long can we go on with ECMO, I believe?
Yes. I answered this that usually up to 2 weeks we can continue. After this, a lot of complications. So we go for other long-term devices, intermediate devices or long-term devices.
I believe Dr. Nirupama has summed it very well. She says we need a lot of mock drills for these special scenarios. Only then we can understand the small inherent important things. Absolutely true.
Madam, I must appreciate the simulation workshop of obstetric emergencies that we conducted in Indore. It was a real eye-opener for everyone. I think these kind of mock drills will only help in near future.
True. So if there are no questions, may I request Dr. Giegel to please, sum it up and thank our chairpersons and our faculty for joining us, especially our delegates also as well. Thank you, sir.
Yes.
Over to you, Giegel.
Good evening, everyone. So it is my privilege to deliver the vote of thanks at the conclusion of this enlightening webinar. First and foremost, I express my heartfelt gratitude to our President, Dr. Naveen Malhotra, sir, Dr. Anju Gariwal, ma'am, President-elect, and Secretary Dr. Vishal Singla for their constant encouragement and guidance. A special thanks to our respected chairpersons, Dr. Madhvi Julakanti, Dr. Shaili Mittal, and Dr. Devyani Desai for their valuable time and contributions. I would also like to sincerely thank our faculty speakers, Dr. Navne Samag, Dr. Vivek Gupta, and Dr. Anju Gariwal, ma'am, for their excellent presentations and sharing their expertise on these critical topics. My appreciation also goes to the RSA Bathinda branch team for their efforts in coordinating and moderating today's session. Last but not the least, I thank all the delegates and participants who joined us this evening. Your active participation keeps the spirit of academic learning alive. We look forward to meeting you again in the upcoming RSA sessions. Until then, stay safe and stay connected. Thank you.
And before we all wind up, I really want to put on record, you all, especially for our younger generation, the enthusiasm and the dedication of our patron, Dr. Tej Kaul sir. He's always there in all our sessions, along with Dr. Naveen Malhotra and Dr. Vishal Singla to encourage us and, to keep learning together. That's very important. Thank you so much.
Thank you very
Over
much.
to you, Dr. Vishal.
Thank you very much, ma'am. It was pleasant and so learning experience for everybody. The discussion session itself, just from 7:15 to 7:45, it itself shows the interest in all the topics, whether from maternal CPR, obesity CPR, traumatic CPR, and ECMO CPR by Dr. Vivek Gupta, sir. It was an excellent presentation by everybody. Thank you very much, and long live RSSCP. I would like to call upon our President, Dr. Naveen Malhotra, sir, to please to say the kind words, sir.
After such academic discussions, have a safe good evening. Good night. Thank you very
Good night,
much.
everybody. Long live Research Society of Anesthesiology.
Long live
Good night.
RSA.
Thank you, sir.